At the University of Pretoria's Faculty of Health Sciences, we believe in unearthing potential. We believe in our students' potential to make a positive impact in society and to produce research that shifts boundaries. In order to help students reach their full potential, the Faculty of Health Sciences has established the Life Changers Fund. Partner with us to help our life changers reach their full potential by contributing to the Student Solidarity Fund. Your contribution will help support students who are in need to pay for accommodation, tuition, food, and procure PPE. Join us and help support our students to reach their full potential. Through any contribution, you can be a life changer too. Developing life changers together.
Good afternoon to our colleagues and everyone that is listening to us. Ndimasiari, Dumela. This is a very important day for all of us because we are going to address a topic that is very sensitive and that is dear to my heart. My name is Professor Mavis Pumulani Murauzi. With me, I'm with Mr. Appel, who will introduce himself, and the other two colleagues are also here in the studio. I've got Ms. Yoste and also Mabaloi. They will all introduce themselves. I'll start from you, Mr. Appel.
Good day, Prof, and thanks for the opportunity to be here. I work in the public sector. I am a father of 6 lovely kids and 6 gorgeous grandkids. I was diagnosed with COVID in June last year and spent 17 days in ICU and 4 days in the normal ward.
Okay, thank you.
Okay, good day. My name is Sister Yoste. I have got a lovely husband and I've got a 9-year-old son. I'm currently the operational manager of a COVID ICU and high care, and for the last year, and at Steve Biko Academic Hospital.
You can continue.
Greetings. My name is Kensani Kosa, all the way from Guyana. I am a senior education specialist under Department of Education in Limpopo. I work with the learners with severe to profound intellectual disabilities and those with learning barriers. I grew up in a Christian family where norms and values were part of our daily bread. My father was a priest. My mother was just a housewife who managed to mold and groom me to be a woman who I am today, using her cultural and inborn knowledge. Unfortunately, both my parents are no more. Now I'm an orphan, but I still stand up and press as a woman. Thank you.
Thank you. 2 of my guests who are not here in the studio, but we will introduce them later on. I just want to introduce the topic of today, which is the moral anguish of caring in COVID-19 pandemic, an Ubuntu perspective. Professional nursing care is multidimensional, and it involves the physical, mental, social, spiritual, emotional, and cultural aspects of care. The delivery of holistic care to patients involves the synchronization of the multidimension, and often it achieves the synchronization of these dimensions of care nursing professional, by ensuring that nursing professionals make a lot of sacrifices that often go unnoticed by patients. The spirit of Ubuntu that we'll be talking about today is a vehicle through which nurses achieve the balance in the delivery of holistic care to patients, minimize compromise to personal care, and receive appreciation for the care delivered. Ubuntu-centered care revolves around people caring for each other, and every member of the community looks out for each other. Even during the sickness of a person, we know that a person is a person through another. So patients expect to be visited in the wards by family members when they are sick, because that is what they feel, that's how they will feel that they are being cared for, and their loved ones still love them even if they are not well. However, during this period of COVID-19, it was difficult for patients, for families to visit their patients. And that really posed a challenge and causes a lot of moral distress to the nurses, patients, and families. The issue of COVID-19 was necessary that patients must not be visited due to the high infectious rate of the virus and the limitation to the hospital visit, which was beyond the nurses' control. However, patients and families were not happy about it, and they felt that there is disruption in care. As the families were not feeling comfortable with it, the nurses also felt really overwhelmed because they have interpersonal relationship with their patients and they want their patients to be happy. And when things are not going according to the way nurses want, nurses often go through what we call moral distress. Moral distress is when there is a clash in your clinical judgment as a nurse and the execution of what is expected of you that is often beyond your control. And in this case, nurses wanted the patients to be seen by their families. However, it was difficult due to the restrictions that were caused by COVID-19. This caused a lot of outcry out there, and patients felt like they're not being treated well, they were afraid, and they felt that their patients are not visiting them. At the same time, the families felt like they have been, they don't know what's going on from their own patients. And this care that was happening during this period, from the Ubuntu perspective, we feel that it was devoid of Ubuntu principles, and it was totally unacceptable according to us, because Ubuntu is about relationship between people. So today we will be focusing on this issue. The purpose of this seminar is just to explore and describe the moral distress experiences by the nurses, the perception of the patient themselves, and the families, and the proposed solution that we can come up, because COVID is still here with us, and there will be other conditions that can occur that will need the same principles to be followed. But we have to, as a society, sit around the table like what we are doing today and say, when we are confronted with issues like this, what are the ethical responsibilities? What are the moral responsibilities? Based on Ubuntu perspective, what can we do to ensure that everyone becomes happy? So this is why we are here today. So I'm going to introduce one of my colleagues, Dr. Wendy Daffa from Australia. She's the president of the Global Midwife and Nurses Rotary Club. She is going to just wish us well for this seminar. She's a mental health care practitioner who has practiced for many years. She wanted to also be part of this seminar, but due to technical glitches, she couldn't be. So she has sent us a video just to wish us well for this seminar. Wendy?
Hello to you all, my colleagues in South Africa. I am Wendy McIntosh, and I am the Charter President of the Global Nurses and Midwives Rotary Club. I have the great pleasure, privilege and delight of working with Professor Mavis, who is a member of our Rotary Club. This is such an important webinar that you're offering. Moral anguish of caring in COVID-19 pandemic. How timely, how necessary. I have a background of over 30 years as a mental health nurse in clinical research and educational roles. I know the value of being there to support our colleagues in the overwhelming circumstances that they are dealing with on a daily basis during this pandemic. I know the value of having information that allows us all to normalise as much as we can that the experience we are having individually is a shared experience. I envisage that your webinar will offer fantastic information to nurses and midwives in your country. A country that has experienced overwhelming costs due to this pandemic, which has also included great loss of life for nurses and midwives. And for that, I'm very sorry. But this webinar will be a great signpost for nursing colleagues, midwife colleagues in your country. And I wish you all a very successful webinar. Thank you.
Thank you so much, Wendy. I really appreciate the words of the well wishes. We really appreciate your words, and we know that you are with us in spirit. You would have really liked to be here with us this afternoon, but nevertheless, we know that things will go well one day. And I will also want to introduce two of the speakers who are not here with me today, and that is Mrs. Tinyeko Baloi. Tinyeko, can you kindly introduce yourself?
Good morning, good afternoon, everyone, and everybody who is watching us. And my word of acknowledgement to my mother, who is the guru to the profession, Professor Mulawuzi, and everyone in the studio. My afternoon words is one day at a time, sweet Jesus. Yesterday is gone, and tomorrow may never be mine. But Jesus, give me strength to do what I can do, and help me by showing me a way one day at a time, sweet Jesus. I am Mrs. Baloi. I am the mother of 4. I'm married to a lovely husband who is very supportive. And I'm currently working at Inlaski Nursing Campus, one of the campus for GCON, which is Gauteng College of Nursing. But for now, I'm currently still recovering from COVID-19. I am free, but due to some complication, I'm still at home. But through God's will, I will manage in this journey. I thank you.
Thank you so much, Tinyeko. We also have the director of Steve Biko Hospital in nursing, Mrs. Muwayo. Will you kindly introduce yourself?
Good afternoon, Professor Mulawuzi, and good afternoon to my colleagues that are seated around the panel, and to everyone who is listening to us this afternoon. I am Mrs. Anna Masilocha Muwayo, and as they said, I'm the director of nursing in Steve Biko Academic Hospital, one of the best hospital in the country, I must say that. I am a lady who raised two beautiful girls after I lost my one child that I had some years back, who left me with a beautiful grandson and who is keeping me on my toes on the new development. I am a recovery of COVID. I was never admitted in a hospital, but I was admitted in my own bedroom where I was isolated, and I think I know and understand the challenges of the topic that we are going to be dealing with today. And thank you very much, Professor Mulawetsi.
Thank you so much, Mama Wayo, as I often call you. We really, really appreciate you being here, knowing very well that you are a very busy person. But you took your time to be with us. We really, really appreciate that. Now I will start focusing on my panelists in the studio. Really, I think you have heard when we were introducing the topic, everyone was distressed. I even called it moral anguish, because I felt it was even more than the distress itself. So I would like you to just quickly, not take so much time, just from you, Mr. Apple, just to explain to us what really happened when you were at the hospital. How did you feel? And, just to give us a briefing so that we can understand better the situation.
Okay, thank you, Prof. I must say, I am one of those guys who are always information overloaded. You know, when I can't sleep at night at 2 o'clock, I switch on the TV and I watch CNN, and then I could see how people die, especially in that time as high tide for Italy, you know, where the morgues were full and so forth. So I had this fear that, you know, what will happen if I can get COVID? And I always told my friends, you know what, if you should get COVID, you must get it now. So because now is a good time to have it, because later on there will be a rush and a fight for ventilators, the doctors, because that's what's happening in Italy. And they told the doctors told, we have to decide who's gonna live and who's gonna die. And I remember there was a march in our community, and I attended this march, and it was on June 16. It was a public holiday. And after that march, a lot of people got sick, actually. And I self-medicated for about a week before I went to see the doctor. And I went to see the doctor late afternoon, about past 5 on a Tuesday. So he said immediately I must go test for COVID. I went to the Wilgers Hospital and they test. And Wednesday afternoon I went to the doctors. I was anxious now. Am I positive or not? Results were not ready. And the Thursday morning the doctor called me 10 past 8. Imagine 10 past 8. He called me and said, listen, your results came back. It's bad. You're positive. You need to go to the hospital. Come and get the referring letter. I already arranged for everything. Went to my girlfriend and I immediately tell her, listen, this is the situation. And I asked the doctor, how long do you think? He said 2-3 days. So I went to the hospital. I'm very fortunate to have medical aid, so I was admitted in a private hospital. I was coughing a lot, you know, it was sore, very sore. And coming to the hospital, but I drove myself, just parked my car, packed a bag with a few things, 3 days stuff, and yeah, went into the hospital. But the next day, it's like things just changed for me. I became very ill. And the coughing was worse, the pain, the whole body was aching, and the nightmare started. I was immediately admitted in the ICU ward. And at the time, we were only 2 in the entire hospital, COVID patients. So, yeah, Then my hell of 17 days basically started in the hospital, in the ICU ward.
Thank you. Maybe we now have to hear from the ICU manager. A patient comes and then now within 2 days, when he walked in, he was fine. He was okay according to what he's saying. The situation just changes after 2 days. What happens? And as nurses, how have you dealt with those situations? Because now when he moves from one ward to another, under normal circumstances, the family must also know what is going on and so on. And in normal situation, you don't even have to call the family because the patient, they will be visiting, the patient will call them and all that. So how did it map out during this period?
Okay, firstly, in my career, I have never seen patients change conditions so quickly. The one moment they will actually be okay, they will be fine, they will be stable, and within the next 24 hours or so, their condition will change drastically. They will be gasping for air, they will be short of breath, they will be in distress. It's really taken all of us for a big, it has been quite nerve-wracking to see these type of changes because it's something us as nurses we are not used to. It's something new to us as well. When it came to the family, specifically in our ICUs, we tried to establish like a telephone rapport, if I can put it that way, where we could phone the families and tell them, listen, this is what's happening. The condition has changed as quickly as possible so that they are aware of what's currently happening with the patient, what we have done, and what is the treatment plan for that patient. And we also encourage, because we all know families do want to talk to the doctors. I really went forward to encourage the doctors on a daily basis to say, can we kindly phone the families and tell them how their patients are doing? What really distressed me is the fact that if someone's not doing well, you will phone the family and tell them, please come in, we need to take rounds, we need to talk to you and so forth. Now it's COVID. Now you can't call that family in and say, listen, come see the patient, physically see what we are doing, what we are struggling with, and what we are talking about, and what are the dangers, and what are we foreseeing for further on, so forth. So and then the next thing is that, do they actually believe what you're telling them? Because they can't see. You tell them the patient's doing okay, and they were like, but sister, can I kindly come and see the patient? But sorry sir, or sorry ma'am, or sorry, you cannot come and see your husband or your wife because it's COVID, there's no visiting time. So to get to a point so that these families can actually believe at what you're telling them. And another thing that I also saw that was really disconcerting for me when it came to the patients is that if you in the past went to nurse a patient, they would actually see you as a person, your facial expressions, how you communicate with them. Now you're in this jumpsuit, the PPE we're talking about. The only part that this patient can physically see is your eyes. And it doesn't, and there's one patient that's been with us, I think, luckily was discharged and everything, and he went well after ICU, after ventilation and so forth, and he came back to talk to us. And what I've realized is they will start identifying nurses by their voices. Even if you identify to say, I am Marina Uester, he doesn't know how you look like. The physical touch and the caring is there, but it's in a suit and it's with gloves, and they can't see you. So how do you trust someone that you can't physically see? So he would say he would lie in bed, and when the night staff or the day staff would come in, he would physically say, I can hear it's sister so-and-so. I can recognize them by their voice. So total dispersonalization of everything. What we are used to is gone. And the fact that that rapport that you build with the families and with the patients are not normal. It's totally abnormal. And it causes a lot of distress. And even when it comes to the grievance process, it's difficult because you have to have some form of closure. How do you have closure if you haven't physically seen your family member? I call you over the phone to tell you your family member has passed on or not doing well. How do you properly grieve for that patient? How do we build that personal relationship that we're supposed to build, that we're currently not building? So it's taken us back. It caused a lot of stress, and I'm really sorry for the families and the patients. It's really not going well.
I think that is what we call moral distress. Yes. Because from your own side, you would really like to help the families. You want the families to see their loved ones. You want them to see what you are doing with them every time. You are not sure when you give them report whether they believe you.
That's true.
You develop what we call moral resilience in the process, but it also takes time. Because according to the caring that we have as nurses, the rapport that we have with patients, the rapport that we have with families is what keeps us going and what makes us feel that we are, doing our best and we are caring not only for the patient, but also the family, which is part of what Ubuntu is all about, relationship between people. But during this time, you are saying it was really, really very difficult. Maybe let's hear from Mambaloi, who was experiencing that. From the other side, your patient has been admitted. The nurse is telling you the progress. And what is also frustrating, you say the condition changes time and again. Today you say, no, she has improved so well, she's doing well. Tomorrow you're telling a total different story. Now we're no longer sure whether the nurses are telling the truth or not. So can you just take us through how you experience all this?
Yeah, again, my name is Kensani Kosa. I had very close family members who were admitted due to this pandemic. The one was my sister that I come after. 4, it was my aunt and my grandmother. Unfortunately, the 4 died. Can you imagine? You just receive this call telling you that they are no more. So my sister that I come after was still alive. As she said, I started understanding what Shakespeare always said, that cowards die many times before their death. This pandemic changed my character. I became a coward because each and every time when you receive a call, you start to shake. Each and every time when you call and my sister don't respond, you die. I started crying because to me it was like she's normal. After, she will respond with a message to say, I'm still alive. But the message was too short, and I'm used to talk to her, using this long message. Then I started doubting, is she the one who wrote this message? Or these are the nurses, they are still waiting for the right time to tell us that she's normal. Again, the trauma. When you call and then she managed to pick up, then you start feeling the breath. She's just dying so slowly. You wish you could be there, and you have this faith that, if I was there, I will definitely do something. And deep inside, there is nothing you can do. And sometimes she will call and say, I'm craving for this sour porridge and gushe. Gushe, it's that slippery veg that we like so much. In hospital, there's no gushe. And the taste is not there. And she's craving for this. And you so wish that, if I could just cook this food and give it to her, definitely she would gain the strength. But you can't do that. You can't. She's just there. The other thing that traumatized me so much, as I mentioned that I grew up in a Christian family, my parents used to tell us that if one of you is not okay, go and play in her room. Make sure that you take food and go and eat there so that even if she doesn't have appetite, when she sees you eating, the appetite will come back. Now I can't do that. My parents are no more. I feel like I'm no more following the norms and values that I've been taught. It's like I'm deserted my family. I can't be there for them. Going back to my aunts, they died. One of my aunts survived, and the other one, they had to prepare funerals. When things were okay, my grandmother will always tell us that whenever there is a function, my grandchildren must come and sing. I'm an artist. So now my aunt will call and say, she's no more, but you can't come and do that. Can you imagine? We needed to support my aunt. We can't go there. Another thing that was so frustrating, you'll always receive calls from family members. They want to know from you because they can't get hold to the person who's critical. What do you tell them? Is she okay? Are you sure? Then after the call, you are going to say, yeah, I think she's okay. I think the moment you say, I think, they think you are hiding something. They start crying. That's why I said we have been dying so many times. And sometimes we'll be calling her when she talks. She will tell you that I'm okay. And suddenly, because she can't breathe, she can't talk, when she drops the call, to me, it's like, oh, she's dead. You start crying. So we died many times. And another frustrating thing, you become useless. You become powerless. You don't even want to see what tomorrow holds for you, because to you it's death, death, death. So immediate, and you can't sleep. It's so frustrating when things are okay. You always worry when other siblings don't call. Why don't you call? Are you okay? But during that time, the moment you see one call from your sibling, what's this? You won't even hold the phone. Now there's a problem. It means she's no more. You start crying. You die every day. Physically, I was fine. But spiritually, mentally, psychologically, I died because of this pandemic, because I couldn't reach out to the most people that I love so much.
No, I agree with you. I think you have said things that are really, really very important. You know, the Ubuntu was not there. You know, that a sharing of opportunities, that sense of belonging, to say now someone has passed on or somebody is sick. You know, when you talked about the inability to go and give the person the food that she wants, from a nursing perspective, we talk about palliative care. When you know that this person, there is nothing that needs to be done, but we want to take care of her during the last times. We want to give her everything that she needs, but you couldn't do all those things. And the inability to go to the funeral too and support each other, the pain, you know. So I really think the Ubuntu part was really not there. And it is something that really was causing a lot of mental distress, not only moral, but mentally. That's why I felt it was important also to invite my colleague, Dr. Wendy, who has been doing a lot of programs to train people on how to deal with issues when you feel overwhelmed, because this was indeed overwhelming. You know, you said something very important, that you died many times. And that is really what people were feeling, you know. And the nurses themselves were also not coping mentally. When she has experienced what she was telling us, who does she, you know, talk to? And how does she get help, you know? So I think those are some of the things that were really, really very disturbing. And I think this seminar today has to come up with maybe strategies on going forward. How can we do this? But before we do that, maybe let's also hear for those that really treated themselves at home. Tinyiko is one of those people that really didn't get admitted. She stayed at home, trying a level best she's also ICU trained. She tried a level best to take care of herself. Tinyiko, can you just maybe briefly tell us what really happened?
Thank you very much, Prof. with me when I was diagnosed with COVID-19. It was on the 14th of January. Well, because I love whatever I'm doing, also as an ICU nurse, as an HOD lecturer. A week before I went back to work, the second week of January, I had that feeling of being tired so well because I study and do this and that. I told myself it's a normal physical tiring. And then on the 11th, I went back to work. I had a sinusitis, which is a general problem to me, so I didn't took it that serious. But on the 13th, my supervisor said, Mrs. Baloyi, you need to consult. Even if sinusitis is your story, go and consult and do the COVID-19, is then that you'll come back to work. I had to secure the appointment the very same day. When I reached the doctor's room, she said, I'm worried about your sinus, but I can't do COVID-19 tests because you don't have any sign and symptoms of COVID. And then I was overwhelmed because I wanted to go back to work actually. So I had to beg her, please, I need this COVID-19 test also. Then she said, I'll give you a form and then you'll go at your own time and then I will let you know if everything is well. Because it was late that Wednesday, I did my COVID test. It was a Thursday. Then Friday in the morning, she called me to say, Mrs. Baloyi, how are you doing? And then I said, oh, my sinus are much better. And then I'm looking forward to go back to work by Monday, but I'm resting now. Then she said, unfortunately, if you didn't receive an SMS, you have to quarantine yourself. Starting from now, you are COVID-19 positive. Well, being a child of God and very having resilient heart, I told myself, I'm not going to allow the spirit of fear to overwhelm me. So I was not worried per se because when the COVID-19 started, when we had a first case around March in Durban, that is where, as a nurse, I remember at the college, I told them, let's have a spirit of those leprosy men. We cannot sit and beg forward. We need to come up with a strategy. How are we going to face this pandemic? Because now it is having a lot before it reach us. So now I started to do the quarantine. When she phoned me, the doctor, I was with my husband because he was not yet back to work as an educator. And then my 4 kids, they were there. The challenge was how to inform the two. They are twins, they're 6 years old. And then I started my quarantine. The other two, I told them, Mommy is COVID-19 positive. The twins, I had to say, Mama is waking home, and then she don't want to be disturbed. But the challenge was on the 17th, it was my birthday. And as a norm, we sing, we shower one another with a blessing, but it was heading another direction. Sunday, when they had to sing my birthday, unfortunately, they were outside. That is where the twins started to think and realize, something is not right with mommy. It's either she's hiding something. They were distressed because they wanted to hug mommy, to kiss mommy. Unfortunately, they were restricted from that. So now, Monday, the sinusitis, it was okay. There started the COVID-19, the real, like, I was like, I'm losing it. But as an ICU nurse, as a spiritual person, I say, no, God has not given me a spirit of fear, but a sound mind. I need to think. It started with a diarrhea, which I don't know how to explain. While I was thinking I'm taking care of myself with this diarrhea, then it was a headache. severe muscle pain, which, like, if I'm to explain or to describe, it was like meningitis. The headache, it was so severe that I feel like I can cut my head because the treatment was not working. And the challenge was, when you are facing these symptoms, when you're dealing with a headache, then the next minutes is something else. I was communicating with the doctor. Well, she told me to monitor myself, the saturation I could see, the heart rate, the blood pressure. That was the nice part of me. But the other stressful situation, as you are feeling these signs and symptoms, the worst severe symptoms, which it was hard, is where you feel like you are burning. Then your chest is so tight. And then from there, you can't breathe. At some stage, I felt like if I can have a fridge in this room so I can go inside and just cool myself. But funny enough, you touch yourself, you are like cold, you are like you are already in the fridge. You are having that air hunger. The windows are fully open, but I had to say to myself, I need to be strong, because the word of God is saying in the book of Proverbs 18 verse number 21, it's saying the tongue is having a power. You can either declare the death or life. It is up to you. So I had to continue to have my laptop on, because sleeping in 24 hours, if I may to say, it was maybe 3 hours or 2 hours. Not because I'm thinking, but because you cannot sleep. How do you sleep while you cannot breathe? How can you sleep while you are burning? It's like there is a fire around in a house. So I kept myself praying to God. Sometimes I was not even having an energy to pray, but I will pray in a spirit, and to say, God, give me the strength. As Prof. Mlauzi indicated, that physically is draining. Physically, I don't want to lie, I'm recovering now. But one day when I look at the photo, the zygomatic bone, you can easily see. And I'm like, no, this is not me. And then mentally is draining, because what happened? I remember one day I was crying when people was phoning me to say, I wish if others, they can just bring cookies, scones, and just put it by the gate just for my kids, because now I cannot do that by myself. And then economically, as I was taking care of myself at home, medical aid cannot cover everything. So your pocket is being drained out day by day. And then it doesn't end up there. Spiritually, people are phoning you. Others, they are afraid because they don't know whether you are living or you are lying or what. But I kept myself to say, I am much better. But immediately I send you the evidence of the vital sign. Is then that you can say, Tinyuko, are you sure what you're talking about? Then I say, yes, I'm fine. I am believing that God is going to pull me through this. And then culturally, like this Ubuntu is saying, cultural, other people, they will be phoning you. Instead of giving you that encouragement, they will be saying, think about something. But if you know, and you are having that strong support, and mentally you are strong, you will know exactly what you need to do. And instead of mocking the very same person, you continue to encourage them so that they know what to do. They passed, but unfortunately on my 13th day, one day to say quarantine is over, that is where I was severely worse. I had to rush to the doctor. Bloods were done. Chest x-ray was done. Unfortunately, being an ICU nurse, I could see in an X-ray that something is not okay, but I will wait for the report. The doctor added some anticoagulant medication and some pain medication as she could. Then I went back home. Around in the evening, that was Tuesday on the 22nd, if I'm still to remember very well. Around past 6 in the evening, the doctor called and then I say, something is not right. She say, Mrs. Baloyi, you need to go to the hospital. Your heart is not okay. Apparently the report is indicating you need to do an MRI. So which hospital do you prefer? And then I'm like, oh, okay, I will phone my doctor. Fortunate, I've got a Professor Kala, who is an intensivist. I have worked with him for a very long time. He is in Joburg jail. So I called him, I explained my story to say, this is the story from the GP. So now he said, Tinyuku, do you need oxygen? Because I know you can take care of yourself. I say 100%, I don't need oxygen. Though my saturation is between 80 and 90, but I'll try my best. I will prone or recover. I will sleep on a recovery position because immediately I'm on a semi-Fowler's position. The heart rate was dropping even to 32 beats per minute. And if you understand 32 beats per minute, actually you are dying. And then the heart rate was having arterial flutter. It was even going to 130 beats per minute. And then I was trying to steam myself. The day I went to the hospital, it was the following Monday. And then the MRI has been done. And then the doctor say you need to continue to take care of yourself, because I beg him, I said, if there is not a thing that I will wish, is not to be admitted. Because if I'm to die, let me die in my house so that my family can have that feeling, not the feeling of isolation, those thing of saying, if I die, did they bury a right person, or what is the whole story? I promised the doctor to say, I will keep on touch, I will do the video vital sign, I will be posting to you, and then if any, I will really call you. And then I monitor myself until around the 27th of February, where I asked him to say, can I go back to work? Because now I am so isolated, I feel like mentally I'm going to lose it, because I just need to be some other people. Then you say, unfortunately, Tinyiko, this is a core week, and then I added core week, standard week, and then primary is then that I will go back to work. I managed to went back to work for plus or minus 6 days, but unfortunately, because my heart rate was still irregular, in short, at work that day it started, and then like I like to joke, I just said to them, my heart is starting to misbehave, can you excuse me? I managed to drive myself back home. It was on the 4th of March. When I reached home, it was not okay, and then I was immediately admitted again in a hospital. It was not an easy experience. The day I was admitted, my baby, the other twin, he came back from school having a severe epistaxis. I'm admitted in Flora Clinic. Now he is admitted at Landmed Hospital. Then now he needs to went for some operation. Because of the protocols of this COVID-19, which is draining, but unfortunately we need to follow it. My husband went for COVID-19 test together with the son. On the 7th, I'm in a hospital. I'm getting a call. It's saying, you know what, unfortunately, I am COVID-19 positive. Now it's my husband. Now it's me in the hospital. It's my son. God, help us to go through this. Give us strength. Then I told myself, let this song of saying one day at a time continue to live in my heart, because now I am shattered, I am dead. And the worst part of it, most of the people, they are looking forward from Mrs. Baloyi for spiritual advice, from the family side, that are looking maternal and paternal to get help from Mrs. Baloyi. But Mrs. Baloyi now physically, she is so drained. Emotionally, she is so drained. But I was much better, and then I was discharged, and then I'm back. I'm in my house again. Though I'm COVID-19 free, but I am still suffering from the cardiac related complication of COVID-19. As I'm speaking, last week, Wednesday, it was on the 24th, I had a heart attack. Around 22 p.m., started to have a chest pain, just a change of position, not sleeping on the lateral, then left lateral. I said, I'm tired, let me sleep on the left lateral. Just to change that position, I had a chest pain, which was followed by sweating, and then I felt nauseous. From there, I had a completely shout of the lower extremities. Like as I'm speaking since last week, I'm living with a hot water bottle for me to survive. So it is not easy. COVID-19 is there. But if we take care and then we support one another, I am happy with you, Professor Mulawizi, for creating this platform to come up with some strategies. How can we help one another? Because when you are alone, the devil get us through the mental state, and then immediately our mental state is not functioning. Physical, we are gone. So if we can come up with the solution of how can we help in our communities, because as a multidisciplinary team, if I can say, I felt this pain, because now when one of my a friend came, she's working in ICU, she was like, Tinyiku, you are in denial. You really need hospital. And then I turn it back to her. I need hospital. You are short staffed. The resources are not enough. That is where she confirmed it is not easy. I appreciate your effort. Few people like you are few. And for now, I am continuously empowering other people. I thank you.
Thank you so much, Tinyeko. I really think your story is touching. It is really something you need to be brave to be able to stay at home and say, I can be able to do it by myself. You went through a lot, but you're still able to speak today and say, I am quite sure that it will be fine, it will be okay. Indeed, what you have said also just shows us that even if you are in a hospital, even if you treat yourself at home, you're still devoid from Ubuntu principles. Because even if you are at home, if you tell people I'm sick and where are you, and I'm at home, can I come and visit you? You will say no. And the people will start feeling like she doesn't really want us to see her and she is really misbehaving or whatsoever. What type of disease is this? If it is COVID, why is she at home, not at the hospital? Because people will ask questions they want to understand. And the issue that you have raised of mental exhaustion also, because the symptoms that you were experiencing, they also make you feel like there is something that is not right. As it has been said here that the symptoms also changes very fast. So I really think that the issues of decision making also came up there as to how and when do I decide that I want to go to the hospital? And what is better, treating yourself at home or treating yourself at the hospital? But we also realize that the issue here is the ethical issues that comes up. You know, the moral issues and the mental health issues are very, very important, that we see how to deal with them. Maybe let's now talk to our director, Mrs. Moayo, just to tell us how did they cope at Steve Biko Hospital, which was one of the hospital which was treating COVID-19 patients. How did they really cope? The staff there, you know, the admission protocols, you know, because people would like to just come in knowing very well that they said this is a COVID-19 hospital. There are steps to be followed, but I'm really feeling very sick. What do I do now? So, Mama Wayo, could you just take us through?
This is a very emotional and very distressing topic to definitely discuss about it, especially as a manager, taking into consideration that my specialty is a pediatric specialty, and that's where I have been working with babies and mothers at the same time. We have got a larger facility, and that helps to see you having the babies and their mothers together. And when COVID came, we also had to release the mothers not to be part of the caring. At the beginning of it, we tried to say, let us keep the mother lodgers as long as we check them on a daily basis. But when it happened that one started to have symptoms and later on tested positive, and when we tried to check the rest of the others, we still found more of them testing positive. We were left with no any other option but than to release all the mothers and close the lodger facility. And that becomes the first pain, to see a child, a baby in a hospital without a mom, without anybody visiting, because it was now too difficult. And that was still in the first wave when we thought we cannot continue, because initially we looked at it in a way to say, if the moms are lodging, they are not actually going home and coming back and collecting COVID. But you don't even know that the mother that you admit for delivery, post-delivery, you admit the mother as a lodger, but that mother, you find that she actually came being positive. The challenge came also when the staff themselves in the neonatal unit became positive also, and you start to have a 50% of staff that is positive. And you know, somewhere is either we have infected each other, and I'm talking about the area where it was not even a COVID area, it was a non-COVID area. Maybe just to give us a short background to say, in our institution, because we are a highly specialized unit, we had to make means of saying, where do we take care of COVID patients? And where do we continue to take care of non-COVID patients? And that is when we vacated the hospital that is next to us, which is Tshwane District Hospital, and to try to make it as a COVID area. And in the first wave, our aim was to make sure that the other hospitals, when they test positive, they can bring to us and they can remain with the people that are under investigation and remain with the non-COVID patients at that time. But during that time, we actually experienced more of our staff that were not in the COVID side who tested positive. And that led to a shortage of staff. And I want to say in relation to the visit, we wished we could have visitors, because you are looking at this short-staffedness of our unit, and you say if the patients can get visitors, it will be much, much better for the patients, because when you don't have enough nurses to sit and talk to the patient, because they can do the nursing issue, but there is a time when you need a social worker. And as we know as nurses, when we train, we actually encompasses all the other profession into a nursing profession. When there is no social worker, you become one. When there is no psychologist, you become one in an institution. And that time, it's time consuming. It needs a nurse to sit with the patient and talk. And COVID denied us that time. If you expect 10 nurses to be on duty, you end up with 6 nurses because 4 of them tested positive. And when the 4 of them test positive, the other 6 are contact people. And now you need to look into it to say, let's look at the protocol that says they must go and quarantine for 10 days. Do we have that luxury of quarantine them for 10 days? Let's check at them. Let's look at the symptoms and those that doesn't have symptoms. And let's look at the proximity of their exposure to those people that have been positive, and those that were not that much near to the people that turned positive. We continue to work, but they are short-staffed and they can't do all the other duties. And that became a challenge where you say, COVID denied us with Ubuntu. It denied us of having people that comes in. And you know, there are times when we will talk with Sister Joste, Rina, and say, and they will phone and say, with this patient, can't we make means? We know we are not allowed. And you know, I'm saying it now aloud here, but I hope nobody is going to follow me on that. Then we will agree, let's get these relatives to come and visit, even if it is one, and you put the person in a full PPE just to come and see, maybe this patient will really make a turnaround and become much better after seeing, because we knew the importance of having relatives. I think it made me also to go back to remember when we were still children, when we were very young and you are sick. You know, when you are sick, you could get anything and everybody could come and visit you. When you are sick and your mom says, what can I do for you? You call all the things that you know that under normal circumstances, they will not buy you chips and sweets and all that. And those are the things that the relatives will bring. Now, even when a relative, we could say, let this one come in and visit because we need this one and that one. And you find that you can't allow them to bring anything from home. I was listening to Mabalo saying, you know, that sour porridge that we needed, we loved so much. Even if you allowed a person to come, you wouldn't allow that, because COVID, you know, it stands on many things, papers and everything. So you try to avoid to have those. And you know, with the visit, what also we discussed was to say, let's have a book where we are able to can write and remind ourselves, did we contact this family for this patient? So that each and every nurse that goes in during a specific shift, he is responsible to phone the family to give them a report of how the patient is. As much as we know that it wouldn't replace the visit, but it became a much better part of nursing care that will make the relatives doubting, but saying, but at least we got this information at the end. I want to say, when you test positive, like myself, I tested positive and I was at home and I was sick. And when the doctor said, Mrs. Moayo, we think we need to admit you. And I said, no, I don't think I need to be admitted. What I need is for you to bring me the monitors so that I can send you all the information. They organized all the monitors and brought them at home for me to monitor and send them the photos. And at the end, the doctor felt, hey, you are not sending us the right readings that we need to see. It looks like you work it up and wait for the readings to be stable and you take a photo and you send us. We need a video. So I started to do a video. But I want to emphasize that when you are there, you are sick, you are trying to look after yourself and nothing, it's very nice in your life. Your headaches are worse. It feels like your eyes are popping out at the end of the day. And when you have got eye drops, you even try to put eye drops, overdosing, because you are not even sure, is it my eyes that are painful? Is it my head? Is it my neck? Is it my shoulder, my chest? You can't even point out what is painful. The pain that comes up is I was sitting with only my daughter at home. We were only two. And she has to do everything for me and put everything at the doorstep. And when she's gone, I have to open and take things inside. And she phoned and she said, you know, it is so bad that you are sick. I'm not sure how you are feeling. I'm not sure if you are not telling me the truth when you say you are better, you are coming up all right. And I am here, but I cannot see you. And the worst part of it was when my sister had to now buy all the grocery, driving as far as Vereeniging to bring them to me. And because of COVID, she said, you know, your yard is a hotspot. I'm going to drop everything at the gate and let your daughter come and take them from the gate, and I'm going to drive back. It was painful because you are sitting there, you wish your sister can come in just even if it is from the window, but she felt, no, your whole yard is a hotspot. I will not come in, but I brought everything that you need in the house. And that is how bad it was. I want to say the hospital phones to try to improvise, because we kept on saying, can't we buy the tablets? Can't we buy the phone for the units? And you find that you have to prioritize other things. But the nurses had to take their own phones to do the video calls. Some of the patients had their birthdays while they were admitted. And the worst part of it is patients that were long in hospital. Others were in hospital for more than 50 ICUs. And now this person is having a birthday. Nurses had to make a birthday celebration for the person. They will bring some balloons, they will bring some gifts, collect within themselves, and bought something for the patient and sang for the patient, happy birthday. And while they're doing that, they will video call the relatives so that the relatives can share into the birthday celebration of this patient that is inside. And when the patient starts not to be able to talk to the relatives, then it becomes more of a pain to the nurses. And that's when you needed relatives to be there. That's when you needed, because at times, you know, the way COVID changes, a patient that you told the relative yesterday that she's doing well, she's improving, she just changed her condition and dies. And now you are the one to phone the relatives to say, unfortunately, the person I told you about yesterday, improving condition, she's no more or he's no more. That becomes a very painful part for the nurses also. And you must know that it happens that it is not only one person who dies. After this one dies, the next one dies, the next one dies. You end up with 3, 4 people that dies. And at times it happens following each other. It follows each other. Everyone dies now. Within 30 minutes, the other one follows. Before even you work your emotions out of that, it becomes a big, someone dies and it becomes a big challenge to the nurses. And that is where we had to try and emphasize on the psychologists, the spiritual people to come and see the nurses. And few of our spiritual people, few of our psychologists were brave enough to say, put on for me the PPE so that I get inside and I talk to some of the patients, as you are saying, they are really not doing well and they need that. During the time in a normal situation, we have got these policies that says the ministers of the wards are allowed to come to the hospital at any given time, as long as they're not coming to see everybody, but they're coming to see their own people. So they are allowed to can come. But during COVID, even the minister of the ward cannot even be allowed to come. He also depend on praying for you over the telephone. He cannot come and visit. Even when you are isolated at home, he can't come and visit. He just needs to pray for you over the phone. And that makes Ubuntu to run away and not be there anymore. And I want to say, as management, people look at you and say, you are part of the policymakers. Is there any other way you could have made for these people, despite COVID, to come and visit? But you are looking at COVID that was new, that nobody knew how it really works. We depended on the people that have gone through the COVID before, the information they give, and you could understand that this is highly infectious. If I expose this family member to come in and visit, and this family member contract COVID, how am I going to feel? And how is this patient also going to feel if now she or he recover and the sister who came to visit does not make it from COVID? That guilt of saying, maybe if she didn't visit, I will still be alive. She will still be alive by now. So you are sitting with this balancing of the two sides of saying, is it right to do it? Is it not right to do it? And COVID dictated that everybody must be a distance from another one. And that is the Ubuntu part of it that really ran away, and that made managers to try to manage, but also to feel that pain, because you manage and you still go through the same. And I want to just say lastly, when I was diagnosed, my niece was diagnosed. And then I was phoned, because everybody in the family knows that you are the person that supports. You are a nurse. You need to be able to help. While you are sitting with your pains, you need to be still able to support the family to say, bring him to the hospital. Then they bring him to the hospital. And when he changed the condition, they still want you to can answer questions. Why is this happening? Why is that happening? What is wrong with him? What is the results of the patient? Can we visit? And that become another burden on you. You are isolated, you are sick, and you still need to look after other people that are sick because they are relatives. And besides that, you are still phoned from the hospital to say one of your staff member has passed on. And you are looking into this, and it becomes such a big issue from COVID to say you have got staff members, you have got family members that are sick, and you are still expected to look after yourself. So those are the challenges of COVID that we definitely need to look forward to say, God help us to be able to deal with the things that we are able to deal with, and those that we cannot deal with, help us to accept what we cannot deal with, and help us to be able to know the difference between the two, the one we can deal with and the ones we cannot deal with, we leave them with God. Thank you, Prof.
Thank you so much, Mrs. Mowayo. It was really a pleasure to listen to you. You have really touched on a lot of issues, more especially from the management side. When we hear you talking about the issue of shortage of staff, we really, really feel that if there were some things that needs to be done to assist really, because we know that those are the things that makes people wonder what is really going on in the hospital. If two people are sick, what about those that were contacts? And what about those that have been supposed to be isolated, or those that are now in quarantine? And I think those are the challenges that the management was facing, and it was really sometimes very difficult for them to also protect their own nurses, because they had to protect their nurses and their families, because nurses are also people that are coming from families, and that on its own is a challenge. So we would like to now move into the issues of the strategies, because we have heard all of you and we have heard what was going on, and we are also now going towards the third wave. We now have a question from one of the listeners who have just asked a question to Sister Yoste and saying, how are ICU nurses feeling about the third wave? Do they feel like they have enough experience now and feel confident, or do they feel anxious when they think of the third wave? Over to you.
Okay. If I have to talk about experience and confidence in an ICU setting now with a third wave approaching, I would say yes. Because we are more prepared, we know what to expect. We have been getting experience, actually getting into experting into donning and doffing procedures, how to protect ourselves and what to expect on symptoms and how patients are. But we still do get anxious because this third wave that's coming, because our first wave was quite strenuous, second wave was even more strenuous. And now the third wave is coming and we're not really sure what to expect. Is it going to be more strenuous than the second wave, or is it going to be less? What type of strain, what type of symptoms are the patients going to be experiencing that's going to be admitted? So yes, we are anxious. If we look at our staff, we're always short of staff. Will we have enough staff to look after the patients for the third wave? We're quite prepared when it comes to beds and ventilators and so forth, but there is still stages in the second wave when the unit was full, and we had to refuse patients from the emergency department or other hospitals because we didn't have a bed available for that patient. So I must honestly give a compliment to the ICU sisters to say they are fierce. If you have to go look, they going in, working every day, not complaining, looking after these patients, trying to make a difference. I've honestly got wonderful ICU sisters that really tackled this pandemic by the horns. So yes, we are better, we are experienced, but we're still anxious, and but we are preparing for the worst.
Yeah. No, I really think that's good to hear that there is efforts that are going on in the preparation for the third wave and so on. But today we're talking about this moral anguish, this moral distress. So I think other strategies that we can also look at maybe is to ask Mr. Appel, you have been there, you have been nursed by these people who were wearing jumpsuits. You could only recognize their voices and so on. We are now moving towards the third wave. If we can say, from your own experience, what do you think could be something that you can say to us as nurses that we can do better?
Well, Prof, I was very fortunate to be in a private hospital. Like I said, when I was admitted, we were only two patients. So the care was fantastic. You know, I cannot say anything bad about the nurses. It was, you know, when when one of our family members are in hospital, we go by the droves. About 10 of us will get there with a lot of things that we bring for him, and then we will eat some of it after he kept out, and then we will sing and we will pray, and then we will leave the hospital. But being in hospital now during the COVID, I mean, for 21 days, not seeing anyone was a real challenge to us. I understand, like the other panelists say, COVID is something new. And I also understand that that visiting should not be allowed, because you can bring the virus in, or you can come and visit and get sick. So I think it's a real challenge on how the way forward. You know, hospitals can't just have video conferencing centers where the patient is there. If you have your phone, you can communicate with your people outside, but it's very challenging. And so I don't really know what to say in terms of how can they improve. It is just a matter of being tough and trust that they do their best, and pray that you will survive the scourge.
Yeah, I would like to agree with you that indeed nurses are doing their best, and they were doing their best.
They were, yeah.
But the one other thing that I thought could be a thing that is confusing to patients, like you were saying, that they would recognize you by your voice. I think it's the environment of ICU itself is threatening. So when you are there already, just by being in ICU, when they are able to talk is fine. But when they can no longer talk, what really happens? I know that some of the hospitals had social workers, and the social worker will just say, okay, this is your time, you can talk to your patient. And then the phone will be put on the patient's ear and you will talk. But that is also very painful. I remember someone saying, how can I talk to a person that doesn't talk back to me? I don't understand this. I can't hear anything. I'm just talking. It's like I'm talking on my own. So I really don't know what we can think of doing in terms of communication. Because I think when people are still talking, she's saying that nurses could give you a phone, you can talk, and so on and so on. But what do we do as, time goes on? We've got social workers. We also have pastoral care. In normal circumstances, we would like a pastor to come in, and some people would say, okay, we would really like our people to be seen by the pastor before they pass on. We want prayers and so on. But those things are not available. So what can we do to bring Ubuntu into this COVID-19? I think that's my question. Tinyiko and Mamuwayo, if you feel you can answer, you can also tell us. But I'm still talking to the people that are here in the studio. Makosa, what do you think?
Maybe I also want to share a little bit, because after caring and after all this trauma, I ended up in hospital. I was also COVID-19 positive.
Yeah.
So the fortunate part, I have the medical aid, but I couldn't go to these best hospitals. The only bed that was left was in the hospital in rural areas. I had to go there. And to me, I say it was so fortunate, because that's where I could see that things are very bad in hospitals. The system is not doing its best. There was a situation where I had to remove my oxygen to give the sister, so that they can give the patient who was coming, who was critical. I even made a clip about that. I was there for 3 days. During the night, I was able to go and exercise. So when I heard that there is a patient who's gasping, I said, please, sister, take my oxygen and give it to the... So what I'm trying to say is that we are coming to the third wave. It was the second wave, but we couldn't have enough oxygens. They don't have enough staff. We had 3 nurses who would work with, we were 16. Can you imagine? I still remember this other time, my drip came off. I had to stay for the whole day without medication because they had to give me medication through. And the sister said, Kansani, I'm coming. She was running. I never saw those sisters or nurses go to the loo. I never saw them eating. And I want medication. I couldn't. Not even coming to the communication with my family. I'm coming back to your point. If they are failing to give me the trip, how would even they have time to come and communicate with me? Because we don't have enough nurses. So it's like you are there. Sometimes you can't even talk to your family members. There is no one in the hospital to talk to you. And not that they don't want. They are running around trying to help. When they are that side of someone is crying, sister, I can't breathe. You know this movement. And I think we do have a lot of people who are ready to help, like our pastors. If maybe we can identify those who are saying, we are ready to stand up and support these people. Because when you are in this situation, you can't even say amen. You can't even pray. You'll just say, God, and then it's like you need someone to say, everything will be fine.
Yeah.
Let me pray for you. Let me tell you positive things. Because whenever you are there, you just see death and nothing else. So I think if we can identify those structures in our communities to say these are the structures that are ready to support our people in these isolations, in this ICU ward, I think it can help. We need support not only from the nurses, but also from other people around the communities who can come and say, okay, things will be well.
Yeah.
But first step, let the system go back to our hospitals and make sure that nurses are enough, so that even if we have 3 nurses who have to be off because of COVID-19, we have other nurses who are on standby to replace those ones so that they come and assist.
Yeah. No, I think you have said your mouth full. The issue is we need resources.
Resources, yes.
Resources, very important. And secondly, staffing. It means that we need more nurses for this. But thirdly, what I liked is the Ubuntu perspective. What does the community say about this?
Exactly.
Can't we have support systems from the community? Can't we have people that volunteers from the community and say, okay, we understand patients don't have people to talk to. I will be a person that will be in ICU. I'll work with Sister Yoste. She will train me. My role will be just to talk to patients. My role will be to talk to patients' families, because I cannot do what nurses do. I cannot do what doctors do, but I'm offering my service, and this is the service that I can offer. And I think that is part of Ubuntu that we are talking about as to what can we do as community members, because we are seeing these things are really happening, and we are, like the question was saying, what do we do during the 3rd wave, you know? And what do we do best, and what do we do differently during that particular time? But I think that is very important. Maybe even the pastors could also say, okay, we are available for pastoral care in the ICU wards. And if we are trained on how to maintain infection control, we are willing to be able to assist in these places. And I think those are the things that we could also look at and see. There is a question there which says, would it be better to use hospital phones for stable patients to be able to call their relatives? Wouldn't that be a better Ubuntu feel? Yeah, I really think. What do you think? Yeah.
I do agree with that statement. It's just when the challenge when it comes to our unit is that there's specifically the one phone on the inside. So they will have to make more phones available. And for us to phone to the outside, you need to go through switchboard. So there has to be they have to give permission to say, listen, okay, they will put the following numbers through for the relatives, because it will now be on the billing of the hospital part, if we look at that part.
Okay.
But I would appreciate it if we've got more phones and I can actually take a patient that is mobile, or you can have, how can I put it, a mobile phone, example, a cell phone, that a certain amount is put on to say, okay, here's a phone, I do understand you don't have airtime, just here's a form of video call. What they have done is, right in the beginning, I've consulted Hospivision, it's our trauma counseling team in Steve Biko, where they physically were, I asked for support to come. Is there someone that can come and talk to the family and the patients and so forth? And we had a lady that volunteered, and she, unfortunately, it would be nice if we more than one, and she actually came and they bought a tablet, and then eventually the whole support, there was a support team, counseling team that was formed, and there was a tablet that was made available so that video calls and so forth can be made. We had that system in place, it's still in place, I just feel we need more hands for that.
Yeah, I really think we can look at that and say, I am a midwife, and in the midwifery we suggested this support system of a doula, where when a woman is delivering, you will have somebody that is supportive there and so on. Maybe we need to start looking at that from the ICU perspective as to, for these cases that we are now struggling with people, when we know that people cannot come in, what can we do to support the patients? Because someone said to me, you know what, I don't think so and so would have died. It could have been the issue of loneliness, inability to talk to someone, and so on. And there is another question that says, this sudden change is from Sanele to Kele. It says this sudden change in condition is also what is causing grieving families to struggle with closure. How do you go through the stages of grief when you are stuck at the denial stage? Like you were saying, today you are told that no, the patient has improved so much, and you are so happy. And then tomorrow you are told, no, she passed on. Then you start asking yourself questions. Someone was saying it seems like hospitals are killing patients because that's what people feel. Or no, if you say a person has improved, and then tomorrow you say no, the condition has deteriorated, or you are not even told that the condition has deteriorated, you are just told that the person has passed on. How do you deal with the issue of acceptance and all those? And I think those are the things that are very important. I think Tinyiko, do you have any suggestions in terms of the strategies going forward?
Thank you, Prof. My strategy, it will be more in the empowerment of the very same pastoral side, where now we cannot deny it that nowadays when people, they go the pastoral way, they think of money. So it will be good if a pastor is a pastor being a servant, when now they are going to counsel based on the biblical perspective. I know we've got the different type of cultures, but if you impact or give this particular person a knowledge, irrespective of whatever, because it's more about what next. All the culturals, they will tell you of, I believe on this, I believe on, but at the end of the day, it will all go to God. The Indian will say it will go to Allah. So if we can pray for the people, when this time come, like we are hitting third wave, you will be like those leprosy men. If you are a community builder, to say, I see it, well, I'm going to die. If I go there, let it be, because I want to fight this. We support one another, because from my experience, most of the patients are dying in this pandemic due to depression more than anything. Because it's like, now if I cannot breathe, what next? Then that is a big challenge. And then as nurses in a hospital, I remember when I was an ICU nurse, praying for the patient in that state of being ventilated unconscious, the patient here. So if we continue to pray for the patient, they do wake up, other than the medical related perspective. And the patient will wake up and they will tell you exactly that, Sister Baloyi, I remember your voice. You pray for me. Other than praying, you told myself to decide if I believe on ancestors, let my ancestors help me. So in this moment of pandemic, we need God more than anything. Then I will go to say in the book of Psalm, I will say, I will see the goodness of the Lord in the land of the living. Only if I believe and not allow the fear to torment me, because it is written, more than 366 in a year. Fear not, in the word of God. I thank you, Prof.
Thank you. Thank you. Mamuwayo, do you have any strategies that you would like to share with us?
Yes, Prof. Just to look back at when we have got the sick patients in the hospital, at times we concentrate only on the sick people and we forget the family members. So when we look at the volunteers should also be taking the family members into consideration to say they need support. They need to have information of what is happening. Because when you definitely know your relative that you were told he was much better yesterday and today he is gone, and most of the time we did not do any postmortems to the patients that died suddenly. Reason is because there are many other reasons which COVID touches on many organs. And one of the things that causes sudden death becomes the clots that it formulates in the body of a person, which when dislodged, it forms also a sudden death. And the relatives at home need more of help to be supported also. When we have got the ministers of the word, they also need to follow up their family members and make sure that they are counseled at the same time. I do agree with the people that can volunteer to come and help in the units and be trained. But you will be needing people that have been counselors before, because you can't train them to be counselors at that same time. The people that have been counselors, the pastors that have been doing counseling also, it becomes easy to teach them only on the part of the IPC infection control. And they will be able to can do that. Currently, as a province, we have opened up for visiting, which we have opened for only one member for 15 minutes. We just did that in a day or two back. So we are still working on how do we work around that. But it was actually excluding the side of the COVID, because we are still looking into how do we also take that into the COVID side so that we still remain safe, all of us. The next part is to say, it is important also for the business companies to come on board. We have got the areas where even if you have got this gadget of the tablet and the phones, the patients can't keep up with having data. So we need companies to say, in such areas where there are COVID patients, let us put up a Wi-Fi, because then it will reduce the burden of having a phone, and now the nurses need to still use their own phone to help the patients to communicate. And other companies can come up with those tablets and not only have one tablet for 37 patients in a unit. You need to have companies volunteering to say, we can buy this tablet for the units, and so that it becomes very easy if you've got the Wi-Fi, if you've got the tablet. And I still believe, even as a manager, that we can still make those one or two exceptions where we will have one person once a week to put on a PPE, so that you have got one person who can really say, yes, I did see the person, tell the relatives, the person is sick, the person is improving, and it will really improve on some of the patients to say, at least I saw somebody that I love, I like. It means I am still worth it, and I'm still loved by my family, and start to also fight on its own. Remember, when you are sick, you also need to bring the will of fighting into the whole part. And the person will fight knowing that I'm still loved at home, and there was somebody else who came once in a while to come, especially for patients that have been long in the hospital. We definitely need to look into how do we allow at least a person to come in, even if we can say the person must be able to bring a result that shows that she was recently in 72 hours tested and tested negative, and so that we minimize all the infection between. And that will also help the patients, and it will bring back Ubuntu into the perspective of all the illnesses. Thank you.
Thank you so much, Mamuayo, more especially about this issue that you are raising. The first issue about the tablets, I really would say we tried a lot as Ubuntu project to get the tablets for hospitals. But it was unbelievable for me when they told us that no, we have given a lot of tablets and data to students at universities. But they couldn't understand the importance of giving that data and tablets to hospitals. They couldn't really compare the two. So for me was education, yes, I hear education is very important, but can you compare education and health when we are talking about life of people? But I saw that maybe we as healthcare workers, we are also not really coming out and giving people information. So having the dialogue also of COVID-19 and what is happening in the hospital, you know, talking about this shortage of staff, talking about this lack of resources, you know, I think this can also help, that if we continue to have dialogues like this in radio station and so on, it can assist. And then the second issue that we have said of saying maybe if we can allow at least one person to come in, it's really very important, because there was I had a relative who was at Mediclinic. They would allow at least one person to come in. Although I questioned it, because they only allowed you to come in when they see that the patient is about to pass on. So why was I not given an opportunity to see her when she still can talk, but I can only be given an opportunity at the end? One person also said in one of the private hospitals, they were only given an opportunity to see the person when she has already passed on. You are given PPE, now look at this person, she has passed on. What is the rationale? Because I wanted to see this person and talk to this person. Maybe hearing my voice could have helped the person to start fighting and saying, indeed, I want to live, my family still loves me, and all those. So those are some of the things that I really think are important, and we have to really find ways of how do we deal with those issues, and how do we put in some of these strategies, so that when the third wave comes, then we are prepared. We are saying, okay, we have looked at these protocols, we can do 1, 2, 3 to make things better. Maybe these things could help our patients to survive. We are not saying it will be everybody, but others we can be able to provide this caring aspect to others, and the caring we know makes people survive. Okay. Makosa?
No, I also wanted to add because I heard she was talking about maybe long-term things to say if we need counselors, some of the people have to be trained. So I want to also to suggest to say we can even have motivational speakers. They don't need to be trained. They are already doing that. So that they volunteer, they come, they motivate our patient. We can even have celebrities who can say, okay, I'm volunteering, I want to come to see the patient in the hospitals. We shift the focus from this thing of saying we are dying. When they come as celebrities, then they talk maybe music. Then we are shifting to say, wow, we still have people who can come. And for example, maybe if it's someone's birthday, and then someone say, okay, I'm going to celebrate this birthday with those people in hospital. So I think it's the shift from the mentality of saying we are here to die. But if they come, the outside world is still with us, then immediately they come, they want to remove us from this hell situation back to the community. So I think it can also work.
Yeah, I think that could also work. And one other thing that we have not touched was the issue of stigma. There was also a stigmatization of COVID-19. Like, if you have been sick with the condition, when you go back to the community, everyone doesn't want to come next to you. And then they feel like you are going to spread the infection. If there was death that was related to COVID-19, it was also a very big stigma that says, oh, you don't go in that they don't even pass there. Somebody passed on through COVID-19 and so on. And I think those are some of the things that we also have to address as a community, that, this is a disease just like any other disease. We cannot be stigmatizing it. We cannot be saying that if this person has suffered from it, then it means that I can contract it too. It doesn't happen like that. So I really think those can be other issues that needs to be tackled so that the communities can really learn on how to live with these conditions going forward and so on. So, Tinyiko, we are just about to go to finish. Could you just give us maybe a few words before we close? What do you think? We have talked about strategies. We have talked about the experiences, and now we are going towards the third wave. We need to be prepared, and when we today we have said that we think that our care was devoid of Ubuntu. So we would like to see a difference when we embark on caring during the third wave. So what are the suggestions? What are the other things, just in closing, that you can say?
Thank you, Prof. In closing, in my case, if we can continue to be strong as a healthcare professional, not in a hospital alone, like myself, I am also running ECD. So that is where I empower the community through parents in the very same pandemic that we are having. And then at church, that is where I'm working in front, trying to let people understand and remove all the misconception so that we are in par. Because now it is better if you talk the language from the healthcare professional with a background, and immediately it add up with your stronghold of being understanding the word of God. Then it went so good, because as I'm sitting at home recovering with my complication, I am still counseling people. And that is where Ubuntu comes in. I thank you, Prof.
So much, Tinyiko. Mamuwayo, your last words.
My last words, Prof, is actually to be very thankful to all the nurses that have put their lives at the front line with the condition or the disease that nobody knew how it was going to come up. The same way that we thought the same second wave will be the same as the first wave, but it turned out differently when we saw young people, people with no comorbidity, demising from this disease and at a very fast rate and at a very high number. But they still remained faithful to their calling, and they continued to take care. We have got many of them that when we started to say, let's allocate you to that side of the COVID, they did not want to be sent to the site of the COVID. But at the end, once they worked for a month, then they sent a message, ma'am, can we stay here forever and not come back? We will come back when COVID is finished. And we want to thank them for the braveness of working so hard. And we are saying, currently, what we are doing with them is to try to have psychological or debriefing sessions for them as part of preparing them for the third wave that is coming, so that when it comes, they are more stable, more calmer, and more, even though currently we still have got patients of COVID, but we are saying while it is still at a low scale, we also concentrate on making sure that we debrief them and help them to work on what has happened and to prepare for the coming part. And lastly is to say, I think from the management perspective, we will look into all the suggestions that have been put up and see what can be possible and what can be put up for the sake of Ubuntu and this platform, Prof. Thank you very much for affording us this platform. It has been a learning curve for all of us, especially to get the emotions that goes through patients by listening to our colleagues. And it will help us to look into the planning of the third wave in a different way. Thank you very much, Prof.
Thank you so much, Mamuwayo. And I think we are moving from what we called moral anguish. We are going to have moral courage now, and we are going to have moral resilience so that we can be able to practice our Ubuntu and be very, very successful in our third wave, and be very proud that our patients have even died in dignity because we tried our level best to ensure that we render care and afford them the care that they deserve. Okay, Sister Yoste, just your last words.
My last words will be, okay, first, thank you for this platform. Something I've been struggling with since the beginning was the fact that we were not able to support the families as we're supposed to. So I would really like us to look into it more on how we're going to support these families and to build a better rapport with them that they can understand what's happening. In the later stage, we started getting more of the people to come in. For example, a patient that didn't want to sign consent. We let the family come in to come and talk to her. So slowly but surely we started putting the families into the unit to start communicating with the patients. And then and to the nurses, you've been warriors. I love you all. And but what I've realized is the fact that we also counsel each other.
Yeah.
Has also helped. If there was a distress or anything, and I would encourage them more to start counseling each other and support each other when there's any distresses. But thank you, Prof.
Thank you so much. Makosa, your last words?
Prof, maybe trying to advise supporters and family members. If we support these people, there are certain things that we can't ask them or we can't say to our patient. Sometimes someone will call, I understand your sister is in hospital. Where did she get this corona?
Yeah.
And suddenly I become so rude in answering that. I used to tell them that I know my sister never went to China. That's the question that I will answer because I'm now frustrated. And sometimes they will ask you, hey, you must also be careful. It doesn't mean that those people who are COVID-19 positive are not careful. So those are some of the words we can't tell our patients or our family members. Let us just support them. And thank you so much, Prof, for
No,
this.
that is that is really, really very true. Where did she find it?
How
and
would
so
you know?
on. And how would you know? So maybe you must just join us. We, as a Ubuntu group, we also in Guyana, we have what we call Ubuntu Guyana movement.
Okay.
We have started making sure that we take Ubuntu back to the community there. And in Esteras also, we have got Ubuntu health and wellness that we have opened there so that we can try to say, okay, as much as we are doing research in nursing, what about the communities and so on, so that we can continue having those dialogues. Sometimes we are even linking with the radio stations so that we can talk about this. So those are some of the topics that we can talk about for people. When a person is having corona, doesn't mean that they've been reckless and so on. And from my side, I would even say those that really take care of themselves are the ones that ended up contracting it, more than those that really don't care much. So it is really very important. Mr. Appel, your last word?
Thanks for inviting me, Prof. I think I wanted to thank my God, my medical aid, and the nurses, and the prayers that I have that pull me through. I think COVID was very new for everyone. Even in first world countries like America, they couldn't cope with all this, this pressure and a new way of doing things, not visiting people, not bringing food in. And I want to give praise to all the nurses, all of people who work in the medical fraternity for the bravery that they've shown, because I don't know if my wife was a nurse, would I have allowed her to go to work? It was like going to war,
Yeah.
So I think really they need more recognition. And when you hear in the news that some provincial government want to cut the salaries by 25% at this stage, you think, what is going on? So
Yeah.
I really don't know. I just want to thank every nurse, everyone in the fraternity of nursing for the bravery that they've shown.
Yes. In fact, what we should be having was to say all nurses in the country are getting 10%, or they're getting once-off bonuses.
Exactly.
Because what they have done, they have really showed us that there is no healthcare system that can survive without nurses. That's what we have learned out of this situation. And I just want to say this will pass. I remember when HIV/AIDS started, we also wore boots, we wore all this PPE. I don't want to remember a story where our first HIV/AIDS patient and how we were so afraid and so on. But as time goes on, we got used to it and so on. So I will also want to believe that with COVID also, we are going to get used to it as we continue, and we will learn a lot out of the situation. But I want to say from the Ubuntu group, we really, really feel honored that we have invited you, you have come in. This is one of the dialogues that we are going to have, and we will proceed with these dialogues. So we are saying we no longer have moral anguish, we have got moral courage, and we will develop moral resilience and endurance. Thank you all.